crowd this morning. We expect a couple more people. Welcome everybody to the TRDRP 5th Annual Smoking Cessation Day Symposium, subtitle Getting Serious About Smoking Cessation. And I'm Theodore Friedman. I'm the PI of the grant, funded by the Tobacco Research Disease-Related Program. My colleagues are Brian Hurley, who's the co-PI of the grant, and Norma Stoker-Matume, who's the community partner of the grant and the main person who organized today's session. And I'll give Norma a big thank you later, and you'll learn more about Norma. But the three of us have worked very hard on the grant and on today's date. We are in partnership with the Tobacco-Related Disease Research Program, Los Angeles County Health Agency, Charles Drew University, French Research Institute, and UCLA Integrated Substance Abuse Programs. All of the financial relationships listed have been mitigated. None of the other presenters, planners, or others in control of the content for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, or reselling, or distributing healthcare products used by or on patients. Please, everybody, mute yourself unless you're the speaker. Please complete the CME and CE evaluation forms. They will be provided through email only for those who remain signed in throughout the duration of the session, for which they are requesting credit. Further explanation is given at the end of the event and at the end of this morning's event introduction. Please use the chat box function for questions to avoid interrupting the speakers. This is very important. This is the start code. I will write this down myself, and you need to write this down for the end. We'll share the code a few more times during the chat.
For anyone that is requesting CE or CME to have this code 1336. Thank you so much. And then for anyone that is requesting CME or CE, if you could rename yourself in Zoom to that name that is on your license, it does help us. It's a little bit easier to keep track of you to ensure that you do get that CME or CE. For example, if you have, for me, like Brianna's iPhone, I would change it to Brianna Lopez just to make sure that it matches my license. So that's just all that we request of you. It just makes it a little easier for us and for you to get that CME or CE.
Our objectives today is that at the conclusion of today's presentation, participants will be able to recognize 3 types of medications used to treat tobacco use disorder, identify the role and mission of the FDA Center for Tobacco Products in 2 ways it is different from other FDA centers, explain at least 2 proposed product standards that the FDA announced in 2022 and how they could help tobacco users quit. Recall 4 items that reflect the spirit of motivational interviewing, identify at least 3 multi-level determinants of smoking behaviors among African Americans, recall at least 2 interventions for smoking cessation of smokers who drink heavily, and explain up to 3 alternative ways to assist a person with smoking cessation efforts. It's a lot of things, but we have an inspirational, busy day today. But the main thing is we want to educate and inspire you to help your patients or clients to change their behavior around smoking. We have a jam-packed session today. I'm giving the introduction along with Norma Matume, who's going to be giving a little video. We have a session from the from the federal government. My good colleague Atul Nakashi from the U.S. Office of Surgeon General will be speaking along with Priscilla Callahan-Leon, who's the Senior Science Advisor at the FDA. From 9:15 to 10, we're having Shanita Hughes-Halbert, who's going to be talking about transdisciplinary research to address racial disparities and lung cancer risk and outcomes. We have a break from 10 to 10:10. From 10:10 to 11 o'clock, we have an exciting talk from Karen Beard, African Americans Who Smoke, Attitudes Toward a Flavor Ban. From 11 to 11:40, Dr. Lara Reyes talking on smoking cessation in clinical trials and in community clinics. From 11:40 to 12:15, we have a great panel that we'll be talking about overcoming challenges in implementing smoking cessation services, perspective from the field. We have another short break from 12:15 to 12:25. From 12:25 to 1:25, we have a discussion led by Brian Hurley, conversations about changing smoking. From 1:25 to 2:10, we have Helping Others to Quit from Tasha Dixon. And we have a wrap up and closing with CME and CE and evaluations from 2:10 to 2:30. Our keynote speaker is Priscilla Callahan-Leon from the FDA Center for Tobacco Products. And Atul Nakashi is the Director of Science and Policy in the Office of Surgeon General will also be talking today. The Tobacco-Related Disease Research Program Community Practice-Based Research Implementation Award was funded in 2018 from the University of California Office of the President. There was 3 projects, including ours. The goal of the TRDRP Implementation Science Award is to conduct health services research that can lead to systems change in delivery of smoking cessation services for low-income smokers, such as the Medi-Cal population. It is funded by the California tobacco taxes, and the program officer has been very helpful, Dorval Hickman III, PhD, MPH. Our project is involved in embedding comprehensive smoking cessation programs into Los Angeles County clinics, and the award number is 28 CP00040. The main purpose of our grant is to expand integrated clinical programs, which includes smoking cessation medications plus smoking cessation counseling. And you'll be hearing about medications and counseling extensively today. We have approval from the DHS IRB and the DMH HSCR. We've had 11 Los Angeles County DHS ambulatory patient center medical homes and 7 DMH operated community mental health clinics. They were randomized into an interventional arm, 9 PCMH clinics, 6 community mental health clinics, and the treatment as usual means there wasn't an intervention. Just the clients, their patients got whatever they were used to getting. 2 were in PCMH and 1 was in the community mental health site. This is a list of the primary the DHS sites and the DMH sites, and the patients at any DHS site could be referred to one of the treatment sites near them. Treatment will be at an existing PCMH or DMH mental health clinic. We did implementation, intervention, and evaluation, including new county expected practices and policies permitting evidence-based treatments. This is done mostly by DHS with behavioral health clinicians. DMH clinics are supported by offering leadership to offer smoking cessation services. And both DHS and DMH have now access to the medicines, nicotine replacement therapy, bupropion, and varenicline. We offer training, technical assistance, and decision support from the DPH Tobacco Control Unit, DHS Addiction Medicine, and our TRDRP funded clinical experts. So the progress on our grant, we've enrolled 406 study participants. We have closed the study now. The study is in its last year. We have over 85% follow-up rate for 3 and 6 month follow-up and 81% follow-up rate for the 12-month follow-up. In the past year, our recruitment efforts have continued mostly through DHS, through referral sources. This includes patient self-referrals, pre-screened lists generated from patient record systems, referrals from clinical providers, which can be sent to our smoking cessation navigators by by messaging the navigators through the electronic records called ORCID, by sending secure emails to the navigators' email, and by using the multi-patient task list for smoking cessation services. And Dr. Balani at Hubert Humphrey was been very helpful in getting our implementation working better, and he's included having a competition for the most referrals. We have successfully engaged clinical staff, trained providers, and staff to facilitate the weekly 60-minute cognitive behavioral therapy smoking cessation group called KICKASH, and train prescribers to deliver the smoking cessation medications at all participating clinics. The study also provided a bi-monthly medical management for smoking cessation webinar led by Dr. Hurley. The webinar is open to all DHS and DMH providers. And all clinics work closely with the study coordinators, also known as smoking cessation navigators, to connect patients with the KICKASH program and medication prescribers to ensure the patients receive the desired smoking cessation services. This lists our number of sites. We have the 9 interventional sites at DHS and the 2 treatments as usual sites. In DMH, we have the 6 interventional sites and 1 treatment as usual site. We can see that we have a lot of patients referred from all sources. About 20% of the patients, 20 to 30% of the patients agreed to be screened. Most of them were eligible for studies. And we ended up enrolling 205 patients at the DHS intervention site, 91 of the treatment and usual sites, with a total of 296 in DHS, and in DMH, there was 87 in the interventional sites, 23 in the treatment as usual, and 110 in the DMH sites. I'm not going to show much data from our overall grant because we're still in this phase of analysis, but it does look very promising here. We expect to conclude the analysis in about May, and we're working very hardly on the total analysis. But overall, the number of cigarettes per day decreased only slightly or not at all in the control group. You can see went from 10.9 to 9.5. That was significant, but really fairly minor. However, in the intervention group, it went down much more dramatically from 10.3 at baseline to 8.4 at 3 months to 6.9 at 6 months to 6.6 at 12 months. And you can see the p-values were highly significant, especially for the interventional group. And then I'm going to summarize a couple of our papers that we were able to publish in the last couple of years. The first one is a paper that Dr. Lindsay Meredith was the first author. Dr. Laura Ray is the senior author, entitled Smoking Network Provider Attitudes Towards Smoking Cessation Treatments. This was published in Frontiers in Psychiatry in 2021. This shows the percentage of the opinion of providers in the DHS clinics in blue, and in the mental health clinics in green, showing how effective is the medicine varenicline, which is one of the main medicines that are used for smoking cessation. And the majority of them said very effective or moderately effective, but a good number were neutral. And it was higher in the the health clinics, the DHS clinics, compared to the mental health clinics. Similarly, how effective is varenicline? When you combine the clinics, you can see most people said moderately effective. So overall, our study published in Frontiers in Psychiatry showed that between agencies, providers largely reported similar attitudes on smoking cessation treatment and expressed positive beliefs regarding the efficacy of smoking cessation aids. Providers slightly or moderately agreed with being prepared to identify and diagnose tobacco use among patients. And the DMH provider stated that the identification of tobacco use was less in line with their job responsibilities and less strongly agreed that varenicline is effective for smoking cessation compared to DHS providers. The conclusions of our study show that providers supported smoking cessation aid efficacy, but may benefit from additional training on identification and training and treatment of tobacco use. These findings support the implementation of specially tobacco cessation treatment programs with training on medications and safety net health care systems, which has the potential to yield large-scale public health benefits. So overall, our study showed that many providers knew about smoking cessation medicines, wanted to use them, but I think we still have ways to go to get more positive attitudes towards them and greater implementation of their use. Our next paper was published, is about to be published, so it's pending, expecting minor revisions in Journal of Addiction Medicine. This paper is entitled Implementation of Specialty Tobacco Use Disorder Services, or STUDS, in a community health setting, support for enhanced prescription practices. And Dr. Meredith was co-author, first author, and Dr. Ray was senior author of this as well. This shows the prescriptions given in primary care in DHS monthly, or actually, I think it's overall in DHS. It's not just primary care. Overall in DHS monthly, and you can see when our grant started, there was about 500 patients, 500 prescriptions given. These are unique prescriptions. And since then, in 2021, it's almost doubled to 1,000. So this shows, I think, that our grant and our efforts to publicize the use of medications for smoking cessation is being effective. It seems to go up fairly linearly. And you can note a little drop here. Everybody would know what happens in sort of the spring of 2020. That's when COVID hit. So there was a little drop here, and then it went back up here. Maybe this is a little dip also for the second wave of COVID. And you can see also that the blue shows the nicotine patches. They were the most widely prescribed. Trans gums were used, were in sort of this orangish red color. And then varenicline is in the gray, also was somewhat prescribed, but maybe a little less. And this shows the rate of the smoking cessation overall. They're used more frequently in DHS. This shows the overall improves for the control group, which is in here, and the intervention group. So the intervention group has a higher rate of uptake compared to the control group. This shows the different type of medicines, and you can see the nicotine gum seems to be the highest increase in prescription rates. The varenicline tablet is in the middle, and the nicotine lozenge is a little less. And this here shows the breakdown in by primary care versus mental health over here. So in primary care, the intervention group had a higher uptake compared to the treatment as usual. In the nicotine gum, all of them really showed an increased uptake, especially the gum had a higher rate of increase. The lozenge also increased. Varenicline increased much more dramatically in the intervention group. The treatment as usual group did not prescribe much varenicline. And this is in mental health. The total prescriptions also increased a little less numbers of prescriptions here, but mental health also had a nice uptake in both overall and in nicotine replacement product. So overall, the monthly changes in the prescribing practice did show there was an uptake with time. It's almost doubled in the 2 or 3 years of our grant. So overall, within primary care clinics, the most commonly prescribed smoking cessation medicines were nicotine patches, nicotine gum, and varenicline. Throughout the trial, all clinics displayed increased rates of prescribing smoking cessation medications. There was a steeper rate of increase among those randomized to the intervention compared to the treatment as usual in both primary care and mental health settings. This work provides support for the effectiveness community-based implementation interventions that promote prescribing smoking cessation medications with the potential to reduce the health disparities among communities at greater risk for tobacco use disorder and its consequences. Then I'm going to go over two shorter papers that my student who actually got into medical school, Sam Kim, and I wrote. Both of them were published in Tobacco Use Insight. The first one is called A New Ingenious Enemy, Heat Not Burn Products. And this is a very fascinating, very scary area. This is made by Philip Morris. They have a product called IQOS. I'd rather quit. It doesn't supposed to mean anything, but it usually stands for I quit ordinary smoking. And this has been actually approved by the FDA. These heat tobacco, but don't burn it. The Philip Morris is trying to make a case these are safer. Our commentary says that they're probably not safer and really caution the use of these products. So Philip Morris says it does not generate combustion smoke when in fact IQOS smoke contains elements from pyrolysis and thermogenic degradation. Philip Morris says contains aerosol that has an average of 95% lower levels of harmful constituents and is much less toxic than cigarettes, when in actuality, the aerosol was found to have volatile organic compounds, polycyclic aromatic hydrocarbons, and carbon monoxide, and may or may not be less toxic than cigarette smoking, as there has not been side-to-side studies, which really should be done. It's supposed to be reduces exposure to harmful constituents to smokers who switch to IQOS. And in actuality, the fact is the calculated lifetime cancer risk of heat-not-burn products is higher when compared to e-cigarettes. Philip Morris states will have a positive impact on a smoker's health. And the fact is, with high levels of nicotine delivery and other harmful constituents, it is unlikely that there will be a positive impact on smokers. Philip Morris claims it does not adversely affect indoor air quality. According to indoor air quality tests, it's not a source of secondhand smoke. And we think that IQS should fall into the same indoor smoking bans as conventional cigarettes and e-cigarettes. Philip Morris states it encourages the potential for full switching among adult smokers, but does not encourage people who have never smoked. Studies have shown that users who have not smoked before are more willing to try these products than ex-smokers. And lastly, nicotine levels are lower in heat-not-burn products. And heat-not-burn products, the nicotine levels are 15 milligrams per gram, which is similar to the level of nicotine in cigarettes. Nicotine levels are more than double in heat-not-burn than in e-cigarettes in short puffs. So fortunately, and this is what we wrote in our conclusion, there's good news, although it may be temporary. The U.S. International Trade Commission ruled that PMI and its parent company, Altria, must stop the sales and imports of IQOS tobacco devices in the United States and stop advertising these products online on social media. This is interesting. This is a decision on a patent case filed by rival R.J. Reynolds. The trade agency found that the cigarette alternative infringed on 2 of Reynolds' patents, and PMI planned to appeal the trade decision. Interesting enough, Philip Morris is going to take over Altria and pay $2.7 billion for exclusive U.S. commercialization rights to IQOS tobacco systems effective April 2024. That's a lot of money, and it shows that Philip Morris is really trying to push forward with this. According to one of the heads of Philip Morris, Dr. Olsak, our commercial plans include full-scale launches in key cities and regions with rapid progression to a national presence. And we really believe that IQS heat-not-burn products could account for around 10% of total U.S. cigarettes and heat tobacco units by 2030. So this is quite scary here. And we're going to be working on trying to educate the public about the dangers of these heat-not-burn products. And then the other paper that we published also in Tobacco Use Insight was entitled U.S. Tobacco 21 is Paving the Way for a Tobacco Endgame. And this is a very important law that was signed into law in the United States following the California law. The California law was passed in 2016. The US 21 law was passed in December 2019. And it requires, they raise the age to buy tobacco to 21. I think this is a huge important law, and this will drastically and has drastically reduced youth tobacco use. Unfortunately, youth are using more e-cigarettes, but the rate of tobacco among youth has dropped significantly even since this law is passed. I think this is a very important law that has went under the table, that really has an important role in smoking, in the end game of having nobody smoke in the future. So some of the what we highlighted in the article, there's benefits of this, that the reduction in youth tobacco use and underage smoking, especially in the tobacco belt states. However, there's still a high number of tobacco usage among youth, especially with e-cigarette use. It delays the age when youth first start smoking. It reduces the use of cigarettes, cigarillos, and flavored products, because all these are banned until 21. And actually, e-cigarette use is really banned until 21. The e-cigarette companies are being much stricter than that. When we first wrote this article, they were kind of lax about the age 21 year cutoff, but now they're being quite strict about it. So I think that data is showing that even e-cigarette use is decreasing recently. It decreases underage attempts to buy tobacco products and increase the age gap between adolescents initiating tobacco use and those who can legally buy them, with things like shoulder tapping. Shoulder tapping, where underage buyers ask other patrons to buy their products for them, still exists in many businesses, as shown by some other articles. And there are still illicit dealers and businesses selling to youth illegally. It reduces the adult number of tobacco use and decreases the number of new smokers. However, with youth vapors, many of them become adult smokers. It increases the awareness of old and new risk of tobacco and e-cigarette usage. The law provides grant funding to states for compliance with the law, pushing states to spread awareness. However, we must keep an ever-evolving market for illicit drug use. THC vapes are gaining traction. It also improves stricter enforcement of the new U.S. law, 21 law, in all areas of the government, including the military. Including enforcement at brick and mortar retailers and online retailers. And it should, and I think there's going to be data coming out about this, reduces tobacco-related mortality and morbidity. However, the challenge is it still may take years for adult smoking use to drop as the youth become adults. But this is definitely going in the right direction. We have these 6 grants, 6 papers funded from our grant. I talked about 5 of them.